hand, I want to say that this is a scary topic, and my intention is not to scare, but to give knowledge so that we have power as a community to do better, and so that you have an understanding of what you need to look out for your loved ones, for yourself, as you speak with your clinicians and your doctors, and what you're concerned about and what tests might need to be done.
Okay, wonderful. Well, actually, before you jump right in, I already see a hand. Bobby, Bobby, you have a question real quick before Dr. Nagpal takes off?
I do. It doesn't concern me specifically. My mother had breast cancer. She passed away 30 some years ago. And at the end of her life, she was not able to walk, and they said it attacked her central nervous system. And I didn't know about this part of a disease back then. I've just learned about it in the last few years through the lung cancer community. Now I'm thinking that's probably what she had without giving me the name of it. Is that what would happen?
It's possible, and that is because when we have leptomeningeal cancer, what happens is we get cancer on the coating of the brain and the spinal cord. So really, it can affect any part of the central nervous system. It doesn't necessarily need to be in a specific spot.
Okay.
So sometimes it is in the lower spine, and it's coating the lower spine nerves, and that's why we can't walk. It happens, we think, in about 5 to 8% of all cancer patients. In lung cancer, it might be a bit higher because it's not descript, like people don't come in with a specific set of symptoms. A lot of times it can be missed. Things like not unexplained nausea and vomiting, headaches, seizures, and then just kind of overall continuing to do poorly and feel poorly consistently are things that patients get sent to me for. At the time of autopsy, from data from the 1970s, shows that any patients with any neurologic signs or symptoms may have had cancer in that space. At a rate of about 20%. We might be higher than that now. Why? Because we're actually better at treating patients for much longer, right? Our average lung cancer patients are doing much better than they were even 10 years ago. And speaking of 10 years ago, the median overall survival from this complication of cancer, where it's on the coating of the brain and the spine, used to be about 14 weeks, so 3 months when I was finishing medical school. Why do I have an MRI here? Well, what I have highlighted with that yellow arrow is actually the abnormal coating of the wrinkles in the cerebellum, or the balance part of the brain in the back part. And this is probably the most obvious place that I sometimes see the MRI become abnormal. If you look further up towards those structures that look like eyeballs, because they are eyeballs, you can see that the wrinkles are like not really that outlined by the dye. But if you look further back in the cerebellum, that amount of outlining is very, very abnormal, and that's consistent with leptomeningeal metastases. It is a really morbid complication of cancer, so that means that it's hard to treat, and patients pass away from it, as Bobby, as you could tell from your mom's experience. So it commonly comes from common cancer. So probably the most common in my clinic is lung cancer. It's also the most common cancer in the United States, right? Followed by breast cancer, melanoma, renal, colon. There are some really, really rare cancers to get to the brain. That's prostate and liver cancer. I usually think that perhaps they have an undiagnosed lung cancer, if that's really what's happening. But it's very challenging to figure out the numbers, right? So I showed you a very obvious MRI, but we're going to talk about why this is actually not easy to sort out when patients walk into your clinic. So this is another very, very obvious looking MRI. MRIs do not usually look like this. Diagnosis can be challenging because actually most of the time it's very subtle on the MRI. It's not these obvious things that we're talking about. And our MRIs are really only about, in solid tumor, like lung cancer, about 8 out of 10 times will we see it on the MRI. So that's that is one of the reasons that it's a challenge, right? 20% of the time you don't see it, and you just have to be listening for all those symptoms. And then we're going to talk more about, once we even get to the point of imaging, why is it even harder? I see a question about, is it more prevalent or higher risk in those patients who have a history of brain metastases? Yes, it can happen more frequently in patients who have brain metastases already. That's like growing in a ball in the middle of the brain, sort of the more classical way we think of brain mets. And I'll talk a little bit about how sometimes our treatment might be playing a role there too. How do we know how many patients? Larger studies have relied on coding, and like medical coding is really notorious. I don't know if any of you have had a bill where it says a doctor didn't code this correctly. We just get this big menu of things, and actually leptomeningeal metastases is buried in there, and you have to get it exactly. You have to type it in exactly right to get it right. So we're not really sure on a nationwide level how often this is happening, but from a center to center perspective, we can kind of tell. So if we look within a single center, and this is a single center, you can see that the incidence, or how often it's happening, the number of patients that they're catching it in, is going up year by year. And this is just from 2001 to 2009. And why might that be? Well, patients are now living long enough. Brain metastases and leptomeningeal metastases are sort of like later usually in the disease process. And so if you live long enough, this is one of the risks, is that you may develop this. There's variable penetration and activity of drugs in the central nervous system. And increasingly, MDs, like your doctors, are getting a little bit more sensitive to listening for your symptoms, and our tests are as well. And it's possible that some of our newer treatments might be, again, playing a role. So what do I mean by that? So having focal radiation after surgery for brain metastases may increase the risk of leptomeningeal metastases. Now, why might that be? Well, you're taking out a live tumor, right? And you're kind of pulling it out through that space that has spinal fluid in it. And you can see here that for patients with breast cancer, this is our center, the 2-year risk of developing this complication is 28%. And we know that in the posterior fossa, so the back part, that wrinkly part that I showed you at the beginning, it may be even a little bit higher than that. So this is something that we as physicians are always watching out for, but something to be aware of as a patient as well. And you can see that risk for non-small cell patients is increased, but not as much as breast. Within non-small cell, this is for EGFR non-small cell, you can see that as you live longer, higher chance of getting brain mets, and also higher chance of getting leptomeningeal disease. So up to 12% of patients at 5 years if you have an EGFR mutation. So here's a little bit what it's a little bit more like, okay, for imaging. This is why it's hard to see. On the left-hand side of the screen, you can see that this is like just smudgy white stuff. And to be honest, there's a lot of smudgy white stuff on a lot of people's MRIs, and figuring out if that's related to your symptoms is something you have to have a little bit of experience with. On the right-hand side is actually one of my ALK positive patients. This is the only slice in the MRI that shows that squiggle that gave us a hint of why he was feeling so bad and he was throwing up. Again, it's something you have to know to look for, and your radiologists have to kind of be on it, because when you think about the number of images we take for an MRI, we're talking in the thousands, right? If you've ever tried to get your CD with all the images on it, single image with lepto on it. So how do we confirm this? Historically, the lumbar puncture was used as the gold standard, which means we get the fluid out from the low back, below where your spinal cord is, okay? So no chance of paralysis. And we look at it under the microscope. A single lumbar puncture, though, will only find the cancer about 6 out of 10 times, even if it's actually there. So that means it's kind of a crummy test, in my opinion. And in the absence of better technology, the way we had been doing this for many, many years of my career is actually to do multiple lumbar punctures to make sure we didn't miss it. I know. See, I see Jane shaking her head. We feel the same way. That's crappy, right? We got to do better than that. But in cases where I'm really concerned, that is what I've had to do in the past. So this test, the C inside test, I have in hibernation here because there's a long story from the company side here, but this is one of the tests that we now use and hope we'll get back in our hands to do a little bit better. So instead of just sending the fluid to our pathologist to look at under the microscope, what this test does, it actually flows it through a column that catches cells that have markers looking like cancer. And then you can actually do additional staining on it. So you can confirm the cancer, and you could actually confirm some of the markers on the cancer. The fluid part then can actually be tested for cell-free DNA. And the importance of this kind of testing, like really being able to see it and being able to isolate DNA that we think is cancerous, Alex, is actually why we do the lumbar puncture, because we want to make sure that the changes on the MRI are not related to other things. The most important other thing, in my opinion, in lung cancer patients is inflammation from immuno-oncology drugs like pembrolizumab, nivolumab, Opdivo, Keytruda. They actually can cause central nervous system inflammation in a small amount of patients. It looks exactly like this. That's why I advocate that we try and confirm using one of these tests. It's why often, even when we don't like to do it multiple times, we do it, right? It's really important to know the difference. I think your follow-up question, should it be checked in someone that started to have dementing symptoms without cancer present? I think it is, again, really important to make sure that those symptoms match leptomeningeal metastases, because there are lots of other things that can cause patients to have problems with memory. And though I didn't mention memory, yes, memory can be a problem with leptomeningeal metastases. Often it's really patients feel ill. So it's not necessarily only that memory is an issue. All right, so we think that this type of testing, when we look at it and compare it against like just looking under the microscope, actually does look better. So this is kind of the math piece of it, but you can see that all of the cases that had cells in the fluid by microscope were all identified by this test, and an additional 13 cases were identified by this particular test that weren't picked up under the microscope. So in terms of like being able to get access to this test, the lab just passed its CLIA certification, so it should be, we hope, back in the hands of clinicians first quarter of next year. And it's on its way. And I think you could say that the neuro-oncology community and the oncology community will be happy to have this back to help patients. So what else can we do if we actually capture those cells? Well, we can actually look at cell surface markers. And so those cell surface markers like MET and NTRK, ROS1, all of those things are targetable. HER2, this is mostly used in breast cancer patients, but is also now more important in lung cancer patients as well, right? Because HER2 has an approval in non-small cell as well. So this is an important marker to be able to see and identify in this fluid, because then I might be able to treat you differently. And the primary tumor may not match your central nervous system. For some reason, we're not entirely sure of yet. HER2 positivity happens more in the central nervous system. So if the cells have managed to figure out how to live there, they're more likely to be HER2 positive than if it's living somewhere else in your body. So again, important for being able to potentially treat and offer different therapies for patients. So that's the cell component. What about the DNA component, right? You guys have heard of Guardant 360. Many of you are getting blood tests to follow, like for minimal residual disease. How are we using that in the spinal fluid? Well, this is my colleague and I published this paper 10 years ago now, just showing that we could actually see the DNA in the fluid, because that was a big deal at the beginning. Spinal fluid is very clean, so you can detect it, but it is such a low concentration that you needed technology to kind of get us there, right? So that's why only 10 years ago, we were just able to see this. This is one of my melanoma patients, and you can see just the graph actually trends with how he did. So the amount of cell-free DNA that was abnormal goes plummeting down when we get his treatment right. And when the treatment stops working and he gets return of symptoms, you can see that level goes back up. So that was, again, this is many years ago, we thought this was happening. And this is a bigger real world view of it from Memorial Sloan Kettering, where patients who've gotten their lumbar puncture, if they don't have any DNA in there, do better than the patients where the DNA has been detected. And it can also help us in cases of multiple tumor types. So I had a patient who has Leptomeningeal, and he has lung cancer and salivary cancer and thyroid cancer, and I think one more, but came in with this brain MRI, which there is more subtle, right? So this is more subtle. This is not an obvious example, but if you can see that there's a little bit of outlining of those wrinkles. So I was kind of worried that there is also leptomeningeal disease here. My lung cancer doctor was like, I can't figure out which one it is. And I said, okay, well, we can tap him, but it's going to be lung. And I was wrong. So this actually turned out to match the salivary cancer. And why was that good for this patient? Because it had HER2 amplification right here, ERBB2. So this patient went on to get HER2-directed therapy for his brain mets. So that's why all this information, it's new technology. Some doctors aren't aware that we can do this even yet. And that's why it's important for you guys to know we can do this. So if you're in this position, this is something important to ask about. There are some real world limitations. To date, no trial validates that treatment changes can be made on liquid biopsy. This is true actually in pancreatic cancer and colon cancer, et cetera. We're still learning. But if it was my body, I would want to know this information. There are limited numbers of companies in this space right now. Belay and Menarini are really the two companies that are doing cell-free DNA. Menarini just relaunched the cell count that they have, and then the C-Inside test, hopefully, like I said, will be launching very soon. So hopefully in the next year, we're going to have better options for our patients. So what do we do when we've found it? These are kind of the traditional tools that we think about. Think about surgery, radiation, chemotherapy, or in the case of many lung cancers, targeted therapies, right? So more often now a pill. And the big news, if anyone is actually kind of read a little bit about leptomeningeal disease, is people are really excited about proton therapy. And we'll talk about that a little bit as well, because I have some opinions. So whole brain radiation, do we still use it? Yes, but really carefully. Why is that? Because you radiate the whole brain and you don't do anything about the rest of the fluid track, right? So this is like a river. The spinal fluid, the reason we can put a needle in your low back and figure out what's going on in the brain is that it's a big river. The fluid starts up here, flows down your low spine, comes back up and gets reabsorbed up top. So if you only treat part of the river, it doesn't really work. But for many, many years, it was really dangerous to treat your whole brain and spine with radiation. And so doing just the brain alone, but not following and not being thoughtful about what that next step is, does not really change outcome. So you need to be thoughtful about how you treat the rest of that compartment. So is proton therapy really the answer? So craniospinal radiation, that's the whole thing, right? Is generally considered an option for children because in adults, it can cause irreversible bone marrow suppression. It means your blood counts go down and they do not come back up. That means you can't take chemo, right? So that's a big deal. So the hypothesis here is that when we use protons, these bigger particles are heavier. They actually stop kind of where you want them to stop. And the image that you're seeing is kind of a heat map. On the right-hand side, you can see the protons, and you can see that the belly and the lungs and part of the actual bony spine is not being covered by the treatment or heat. On the photon side, you can see that there is sort of, your abdomen's getting covered, your lungs getting covered, and most of the spine is getting covered. So that's where we think the toxicity difference is. So it's about systemic toxicity and not really about central nervous system toxicity. As more centers offer protons, including mine, we're about to open our proton center to our proton chair. It's going to be really important for us to know as a community when we want to use it and when we don't. It may improve progression-free survival and overall survival for patients who don't have other options. The downside to this study, and Jonathan Yang and I are good friends, is that no one really does in-field photon. Like we're not really comparing apples to apples here. We're comparing apples to oranges, right? If you're just doing a teeny tiny piece of the compartments, as we talked about, it's not really addressing the whole problem. So it's not a fair comparison. For patients who can get proton CSI, it may be helpful. But it is still whole central nervous system radiation. So as a neuro-oncologist, neuro being the first word, I'm brain-centric, and I want to protect your brain. We know the downside of radiating the brain is that it can accelerate dementia. So 1 month after radiation, you see a little bit of the smudgy white stuff is essentially radiation scar tissue. That's the simplest way to put it. 6 months later, you can see there's more, and 12 months later, there's quite a bit more. What does that equal? That equals memory being challenged. Sometimes the walking program can't walk as well. Sometimes can't get to the bathroom in time. Sometimes we're not interested in getting to the bathroom in time because our motivation goes down as well. So proton CSI can stave off the disease for a while, but can come with these complications. So I think it's just very important to have these conversations with your clinicians if you're considering it, if you're in that situation where you need to talk about it. But do we always have to use the big guns? Can we treat meningeal disease with systemic therapies? I think the answer to that is yes. Tyrosine kinase inhibitors, these are the pills, have really changed the game, but we haven't won it yet, right? So this is a patient with BRAF V600E mutant melanoma, and you can see from the top to the bottom that just pill alone, no radiation, you've got a nice response here. And it's just with vemurafenib, so the first generation BRAF inhibitor. And many of the drugs in that first generation, you're talking about duration of response around 9 months. And previous to these drugs, melanoma's overall survival with lepto was also around 3 months, so similar to lung cancer. And we're seeing similar things in lung cancer. This is the Bloom study using osimertinib, which is a third generation drug, right? So erlotinib, gefitinib, the first generation drugs, OC beats them systemically as well. But also in the central nervous system, you see a duration of response that is almost equivalent to the rest of the body. So this is really kind of an amazing big step for patients. And it means that if I can give these patients that pill, I would rather do that than radiate your whole brain, right? So, and we know that just moving from old chemotherapy and using whole brain to these new small molecules, including actually pemetrexed, which is a chemotherapy. This is a publication from Stanford from 10 years ago, where you can see that we already 10 years ago had moved this line. We have not yet redone our data, but I think this is actually out quite a bit further at this point. So patients are doing a lot better than they used to. And here's some kind of exciting news from ASCO 2024. This is the big, like, all cancers meeting. This was hidden in the neuro-onc section, though. It was a cool study done at Memorial Sloan Kettering where patients who had brain metastasis or leptomeningeal metastasis from lung cancer, EGFR mutated lung cancer, and had osimertinib before. So they'd already had that third generation drug. Were able to get this combination of a pill and a IV medicine that is a bispecific antibody, targets EGFR and MET at the same time. And what did they show? They showed progression-free survival in the brain mets and leptomeningeal metastases cohorts that were actually really pretty, like, these are big numbers, right? So if you look at the overall survival in a patient who's already had sort of the best treatment, you're adding an extra 15 months if you're able to tolerate this chemotherapy or this particular combination. So this was a huge win. Again, it was kind of hidden at ASCO, and I'm constantly sending this set of slides to my lung cancer colleagues. It's not an easy set of drugs. There are definitely treatment discontinuations because of rash and infusion-related reactions. I think we're getting better at treating the infusion reactions, though. But you can see response. So this is one of my patients. I don't know if you can see now that you've looked at it a few times, the outlining on the right-hand side on the pre-treatment is much better. Post-treatment, this is not radiation, this is drug alone. And so what can these systemic drugs do for all, like other patients? So this is a small group of patients getting Enhertu, a HER2-directed antibody connected to a drug. So the antibody carries the drug to the cells. This is in breast cancer patients who have leptomeningeal metastases. And you can see that some of these patients were 500 days. So we're talking about multiple years of additional life on these newer drugs if we can find the target and they work well. This is what happens when you give me a new drug. I use it on lots and lots of patients. Unfortunately, we did not have a ton of non-small cell patients, but you can see on ours, the longer the arrows, the longer the response, and the pink is the amount of time they spent on this drug. You can see that we also have seen responses, and we are now using this more in our patients with non-small cell, especially if they have HER2 in their CSF. And we have other drugs that are coming, like TROP2 inhibitors that are attached also to an antibody, to a drug. And this doesn't look quite as good, right? Why does it maybe not look as good? Well, there's a target difference. So TROP2 is not HER2. A payload difference. The actual drug in this case is different than deruxtecan. You can stuff a different number of drugs onto an antibody. I think this is a 4-to-1 ratio as opposed to deruxtecan. Trastuzumab deruxtecan, I think, carries 8 of those molecules. And the linker, how it comes apart in the cell, can also be different. So do I use sacituzumab? Sometimes, not my favorite, but there are definitely patients who get response. And this is a study that I put in here. If anyone's been following the HER3 story, I put this one in here also because it was a little bit hidden at ASCO, but very exciting. Exciting not only in that, it has some interesting data for leptomeningeal metastases and brain mets, but this study was run by a major company, and it was entirely for brain mets and lepto and lung cancer. I mean, and in breast cancer as well. But like that, to me, a person who's been in this field and who's been begging to have our patients included on study, this is a huge deal. It's, Daiichi coming to the table and saying, yes, you guys are important. Like, yes, once you have disease in the brain, we still need to figure out how to treat you. So even though the drug is still kind of turning around for potential approval, I think this is a big step forward for all patients with brain and leptomeningeal metastases. And what we can see here is that the patients with leptomeningeal disease actually had a pretty nice 6-month overall survival. Again, these are patients who probably have already had 3 other sets of drugs before, like the ones that I showed you. So I think we're making some significant progress here. Unfortunately, the big Herthena study did not hit on OS, but the LMD subset has caused some excitement. So I'm hopeful that we're gonna see continued development of this drug. I get a lot of questions about using immunotherapy in the central nervous system. There are immune cells in the central nervous system. They can be active. We just don't know enough about how they work just yet to really figure out how to use them and harness them for leptomeningeal metastases. But rest assured, we actually have a pretty good number of scientists who are now starting to work on it. So when you take the off-the-shelf drugs like pembrolizumab, ipi/nivo, so these are Keytruda and Opdivo, and you just give them when a patient has enhancement on their MRI, it doesn't really seem to help that much. So I think we need to be more thoughtful about how we use them. And actually, I should have included this here, but there are some really exciting studies coming out of Moffitt Cancer Center using dendritic cells into the fluid to target cancer cells. And some of the patients on that study have done really well. So I'm excited to see where that goes. And, if that's something that ends up being usable for patients who also have the HER3 target in lung cancer. This is a specially engineered chemotherapy that can ride across the quote blood-brain barrier that we are trying here at Stanford. And this study just closed. So I would say lung cancer LMD can enroll and did enroll, and we are now doing the data. So this just closed. Hopefully I'll have updates for you. But the purpose of putting some of these studies in here is really to show you that there are studies out there. They are happening, and research is happening in this space. Okay, so intrathecal therapy. Some people have heard of this, some people have not. What does that mean? That means actually putting the chemo, you can see the picture there, putting chemotherapy or a treatment directly into the central nervous system. We think that when you put the chemo in right here, it really only penetrates a millimeter or two, right? So we're really talking about the cells that are on the coating of the brain and the spinal fluid. We're not talking about hitting brain metastases that are growing as a ball. So what is this study showing? It looks old. It is old, actually, but it is intrathecal. It's intrathecal methotrexate versus giving it IV. And it turns out if you give the medication that works by IV, it actually does better, right? So this kind of supports the idea of like, hey, if I can give you a pill, I can give you IV, we're going to do better for patients who can tolerate it. Now, when do I use intrathecal therapy? Well, when we think for some reason that drug is not as active in there, one of those drugs is Herceptin. That's a HER2 targeted antibody by itself, no drug attached, that we've started using for patients who have HER2 on those cancer cells, right? This is mostly breast cancer patients. This is also data from Moffitt Cancer Center. You can see that patients who get intrathecal Herceptin do better than patients who are getting other forms of therapy and even whole brain radiation. So for drugs that maybe aren't getting in as well and aren't as active unless you put them directly in, there is probably still a role for intrathecal Herceptin. I use it a lot in my patients. I have a picture of a patient who wanted me to use her picture at the end of this slide deck. So what about putting immunotherapy directly in? Well, Bella Glitza at MD Anderson has been trying that. Not really clear that it's making an overall survival difference for all patients, but you can see there are some patients where we are having some response, right? Like this is a half a year on getting therapy through here. And to be clear, antibodies actually are pretty well tolerated when we put them in there. The biggest pain for the patient is that you guys have to come see us at least once a week. But generally speaking, like the intrathecal Herceptin patients, that's their biggest complaint is that they have to come see me once a week. Is it safe? I think this is, yes, these are all like patients having a grade 1. What does grade 1 mean? It means you tell me about it, but I don't really need to necessarily intervene on it, maybe some Tylenol. So it seems like this particular strategy is safe. Pemetrexed, another drug that's used a lot in lung cancer, we can also put that in the central nervous system. I think the data is a little bit more murky here. It's not clear to me that it's actually helping or not, but we've had at least case reports where we've used it and patients have actually responded and done really well. So I think carefully selected patients, we can use pemetrexed as well through the port. It comes with its own risks. Similar to radiation, you can get that smudgy white stuff. This term leukoencephalopathy is the smudgy white stuff, fancy term for it. So in conclusion here, I would say that I am looking forward to more and more CNS active drugs. There are multiple new drugs in the pipeline that have CNS penetration, CNS activity, and a lot of things that we never thought in the past, or I shouldn't say we, a lot of people thought wouldn't work. I was always like, it's not about the size. It's about if it actually works. They're all under, investigation. And that's part of why I included all of those studies there, is to show you that people are thinking about it. And we're trying to get these drugs to patients who have brain disease. And if we know how to use these drugs better, it may mean we can delay or avoid CNS radiation altogether and improve overall survival. So this is my patient, Deb Marshall, who at the point of this picture was 2.5 years from her diagnosis. Remember, we have that prognosis talk with your doctor. We generally give you the numbers we were taught, right? So I said, Deb, I think we're in that maybe 3 to 6 months range here. Let's I'm going to treat you with intrathecal Herceptin. I've never done it before. And let's see where this goes. And she said, okay, you're telling me to do all the things I want to do. I'm going to travel right now and I'm going to go build a school in Nepal. And at 4 years, she told me, Dr. Nagpal, I think I'm going to run out of money. And I was like, can you believe that this is where we are? This is like a, kind of a crazy good problem to have. And she actually passed away at 4.5 years after I met her, getting intrathecal therapy, did not pass away her central nervous system cancer. So really thoughtful care and brave patients. I think we can do things. You just have to be creative. So that's a lot. I put a ton in here for our patients, for our friends, our daughters, our sons, our moms, and our dads. We need to do better, faster. So, that's where I am, and that's what I want to do. And I hope that you guys found that helpful.